Hello guys, this is Kay and you're listening to Pod Rainbow Science. And in today's episode we're going to talk about sexual dysfunctions in LGB men and women. Let's start. Hello everybody, once again I'm really happy to have you here. I had a pretty tough week since I had to prepare exercise and lectures about qualitative methods and everything would be fine, but the problem is that I don't really use qualitative methods. So I had to make some things up and actually learn myself about qualitative research approach, and I had to talk about things I've seen 7 or even more years ago for the last time, so it took me really long to recall everything I know about qualitative research methods. But I hope it was fine. At least people were listening and they seemed to be interested, so I think that all went good. And another good news is that our paper was accepted. I mean, they accepted it, but they require minor changes, so I think it's gonna be published within 3 weeks, and of course I'll let you know when it's ready, and maybe I'll be able to share it immediately after it's published. And the paper is about sexuality of men, bisexual and homosexual men, and their sexual dysfunctions and the general sexual behavior in bisexual and homosexual men. And honestly, I almost forgot about this paper for a little while because it took about 8 months between submitting and getting the reviews. So it was 8 months waiting for the reviews. So I seriously almost forget about it. We sent it. But a good thing is that this paper actually served as an inspiration for today's episode. Because I'm going to talk about a little bit about sexual dysfunctions in gay men and bisexual men, and of course bisexual and lesbian women. I'm not going to talk about transgender people this time because I think it's an entirely different issue, because sexuality of transgender people and gender diverse people is very different from cisgender ones. And there are many different factors that can influence gender diverse persons. So I think I'm gonna talk about it in one of the next episodes. And today I just want to concentrate on cisgender LGB people. It is pretty obvious, I guess, that sex life is one of the most important part of our life, and it is pretty important for our relationship quality and for our overall health and life quality and our well-being. And also sexual wellness is one of the most ignored problem in contemporary medicine, because doctors and physicians usually concentrate on our physical symptoms, and the relationship between physical health and sexuality is still oftentimes neglected. And still, it is sometimes considered as kind of taboo, I guess. I see this problem very often, especially in the patients who are on antidepressant drugs. And you probably noticed that many people take antidepressants nowadays, not only LGBT people, but people in general, and especially after the COVID pandemic. And the problem is that many drugs prescribed for depression have very unpleasant side effects, and one of them is very low or almost no libido, no sex drive. And many people don't realize that, and seriously, it's one of the most prevalent side effects. And additionally, unfortunately, psychiatrists do not inform people that it's going to be like that. So when you have no sex drive, or you're unable, for instance, to maintain erection, you can experience shame or even greater depression. And because of that, some people are scared or ashamed to tell doctors about their problems, and consequently those sexual problems or sexual dysfunctions are deepening their depression, and this is kind of vicious circle. They have depression, take drugs, those drugs lower their libido, and worsen their sexual functioning, what is increasing their depression. And this vicious circle is spinning. And if they only told their doctors about their problems, they could get another drugs, just different type of drugs. For instance, instead of SSRI, they could take MAO drugs, which don't have such a huge impact on sex life or sex drive. It's all possible to fix and regulate, but just health specialists must know what's going on and what's your problem. They cannot guess what's your problem. But the problem with sexuality and sexual dysfunctions in men and women who identify as lesbians, bisexual, or gay is that the most of sexuality studies in this group focused on HIV or other sexually transmitted infections, or on the other hand, sexual study focused on relationship issues, and especially in the case of women. The scientists were focused on relationship quality, trust in a relationship, lesbian bed death, and things like that. And sexual pleasure and sexual wellness were never the key issue for sex researcher. But things have changed, and some time ago, scientists just realized that gay, lesbian, and bisexual people enjoy sex life, and as such, sex life of them should be described and assessed using a proper scientific approach. However, on the road to sexual wellness, some people may encounter sexual dysfunctions, which can be defined as any problems that prevent a person or a couple from experiencing satisfaction from sexual activity. And according to studies, about 45 sometimes percent of women and about 30% of men experience some degree of sexual dysfunction over the course of their life. So, in my opinion, this is substantial proportion. And what's interesting, many of those problems could be addressed and get rid of pretty easily. But it's not happening because of the shame people feel and because they are reluctant to go to the doctor's office. So even if you experience whichever dysfunction I'm talking about, even if they bother you, you feel distressed, just don't worry, go to your doctor. I can almost promise you that it's gonna be treated within like a month. And by the way, it's very, very likely that the doctor had a lot of patients like you. According to studies, in the population of MSM, which stands for men who have sex with men, the prevalence of sexual health issues and sexual disorders varies from 42 to even 79%. So this is definitely higher as compared to the general population of men. And what's interesting, those studies were conducted on HIV-negative populations. So it means that those sexual problems and sexual disorders were not related to their HIV status. The most commonly reported sexual symptoms were low sexual desire, low sex drive, erectile dysfunction, premature ejaculation, sexual performance anxiety, and anorgasmia. I'm gonna briefly explain all of them. So, starting with low sexual desire, this is probably the easiest one. Loss of libido, loss of sex drive is one of the most prevalent sexual dysfunctions among both men and women, regardless of their sexual identity. And it is often linked to the relationship issues, stress, but it can also be related to medical problems. For example, the reduced hormone level. And low sex drive is also very common among people with depression, among older people, or even among pregnant women because of fluctuating hormone level. So you see, the underlying cause can be multifactorial, and as such, it should be diagnosed. And depending on the underlying causes, an appropriate treatment should be applied. So the treatment can include changing dietary habits, sleeping habits, cutting down alcohol intake, sometimes counseling, and when a cause is more health-related, treatment includes changing medication or hormone replacement therapy. So this is really easy, but just the key issue is to find the proper cause of the disorder. Another one, which is erectile dysfunction, is usually defined as inability to get or keep an erection firm enough to have a full sexual contact. And some time ago, it was referred to as impotence, but it's not exactly the same thing. And also, this term impotence is not used anymore. Maybe some older doctors would use it, but I don't think so. However, I think it's very important to underline that erectile dysfunction could be diagnosed when you are completely unable to get an erection, but also when you are unable to maintain firm erection, firm enough to have satisfying sexual intercourse. So you can experience erectile dysfunction even when you actually can get an erection. And erectile dysfunction can be, of course, related to relationship issues, psychological issues such as depression or a high level of stress, but it can be also linked to a serious medical condition which should be addressed immediately. So if you start seeing the problem, you should definitely consult your doctor. So from the technical perspective, erection is caused by the increasing blood flow in your penis, and it can be caused by either thoughts or direct contact with your penis, which force muscles in your penis to relax and your blood can flow to your penis. So this would be the easiest way I could explain what is erection. And according to variety of research, erectile dysfunction could be related, besides psychological and emotional problems, it could be related to cardiovascular disease or hypertension. It can be related to diabetes, high cholesterol, obesity, lower level of testosterone, drug and alcohol overuse, but it could be also related to more serious conditions such as Parkinson's disease or multiple sclerosis. So if you notice that you or your partner start having problems with erection, I would definitely recommend going to the doctor and consult it. Maybe it is bullshit, but maybe it is something serious and something that needs to be addressed immediately. Treatment usually starts with changing the habits that can impair your erection, such as smoking or drinking alcohol, or increase. Maybe the doctor would suggest increase physical activity level and so on. But more advanced treatment includes oral drugs such as Viagra or Stendra, or testosterone therapy when the problem stems from low testosterone level. Sometimes you can also get some kind of equipment to manually stimulate your erection. It is called the vacuum erection device, and it literally works like a vacuum that help to get an erection. You can look it up on Google, but in the vast majority of cases, changing medication and lifestyle is fair enough to get rid of the problem. The next one, premature ejaculation, is pretty common sexual dysfunction, but it is also quite controversial one. And according to science, premature ejaculation occurs in roughly 30 to 40% of men, regardless of sexual identity, and it can be diagnosed when a man has an orgasm or ejaculate early during sexual intercourse. And by early, I mean earlier than he or his partner would like to. So in the case of the vast majority of men, it is caused by psychological factors. However, a small portion of men experience it due to chemical imbalance. And the very important thing is to mention that those people who grew up watching porn movies and those guys who think that sex life looks exactly like this pictured in porn movies, they're going to be certain that they do experience premature ejaculation. And because of that, premature ejaculation is prone to, because of that being prone to subjective assessment and personal bias, sexologists came up with time frame to assess whether it does or does not occur. And according to the guidelines which are used nowadays, premature ejaculation that occur within a minute can be diagnosed. So when you start having a sexual intercourse and you can't keep your erection without ejaculation for a minute, you could be diagnosed with mild premature ejaculation. And of course, the underlying problem can include performance anxiety. It would be one of the most common psychological factors, but also stress, also depression. And when it comes to physiological problems, premature ejaculation can stem from hormonal problems, like, for example, trouble with oxytocin level, low serotonin, or low dopamine levels. Or you can be one of those guys whose penis is extra sensitive to stimulation, and that would be the reason. But the good news is that premature ejaculation is pretty easy to treat, and in the vast majority, if not all cases, it can be fixed pretty quickly. It is also this kind of dysfunction which has the most pleasant treatment, because treatment includes auto-stimulation and masturbation. For instance, before the intercourse with your partner, you can masturbate to delay ejaculation. It can also include pelvic floor exercise. If you want an immediate effect, you can use the condoms to delay ejaculation. And you can look for those condoms which contain benzocaine or lidocaine. Those are substances which can decrease sensitivity and delay ejaculation. And also, sometimes when a medication is necessary, the SSRI can be applied. And SSRI is one type of antidepressive drugs which can also delay ejaculation and which can a little bit lower the level of sensitivity of your genitals. And the final dysfunction is called anorgasmia, and it is in general the persistent inability to have an orgasm even when being sexually stimulated. It can affect both men and women, and it is more often diagnosed in women. However, roughly 8% of men are affected by anorgasmia, so it is not so rare in men either. And I think it's pretty important to underline that anorgasmia is often confused with delayed ejaculation in men, which is the situation when orgasm is possible, but it is difficult to achieve, or it takes really long to achieve. Anorgasmia is diagnosed when you are completely unable to achieve an orgasm. And anorgasmia can be related to psychological issues like really high level of stress or cognitive overload, because when you're thinking about all your problems or thinking about something so much and your thoughts are so intense that you can not really concentrate on your sexual performance. So in your mind, you're somewhere else than with your partner. It is not difficult to imagine that it's hard to achieve an orgasm. However, this is most often related to physiological problems. For instance, nerve damage caused by diabetes. It can be also a congenital situation. It could be the result of substance abuse, especially heroin abuse, or it can be the result of taking certain medication, for instance, antipsychotics or antidepressants. And additionally, it could be a side effect from surgery, like, for instance, prostate surgery. Since it can stem from different reasons, treatment of anorgasmia is directly linked to its cause. So treatment can include psychotherapy, replacing medication, or increasing stimulation while having sex when the problem is related to reduced level of penile sensitivity. But the treatment, it must be highlighted that treatment must be directly related to the cause. So to sum it all up, as you can see, the vast majority of sexual dysfunctions in men could be related to both physiological and psychological factors, such as stress or cognitive overload or depressive disorder. So this is not surprising that minority sexual men could be more exposed to sexual dysfunctions. And as the group which is especially prone to such symptoms, they require our attention, require attention from psychiatrists and sexologists to help to alleviate the negative influence of minority stress on sex life in men who have sex with men. In the case of women, The vast majority of studies on female sexuality and female sexual dysfunctions was focused on women who were young, who were in reproductive age, and who were heterosexual. There's not much information about lesbian women and their dysfunctions. However, I found some studies that would shed light on sexual problems among this group, among bisexual and lesbian women, or to be more precise, women who have sex with women, because not all of those studies are based on a women's identity, but the vast majority based on the behavior. So when women indicated they had sexual relationship with women, at least one sexual relationship with women, they were classified as WSW, which stands for women who have sex with women, regardless of their sexual identity. The interesting part is that in literature about female sexual dysfunction, there are no studies investigating medication-induced sexual dysfunctions. This is interesting because, for instance, anorgasmia is often linked to medication or substance abuse, and substance abuse, including medication abuse, is quite often in sexual minority women. So to be honest, I would absolutely expect the relationship between those two factors. But of course, I don't want to talk about things I'm not entirely sure, and since I don't have any literature to support my hypothesis, I can only tell you that this is my presumption. But anyway, according to the literature on the women who have sex with women, there are three major themes that are described, and those things that emerged from the research are: first, female orgasmic disorder, second, arousal or sex drive disorder, and finally, pain-related disorder. And I'm gonna also describe them consecutively. And starting with female orgasmic disorder, it is defined as persistent or recurrent delaying or absence of orgasm following normal sexual excitement phase. I think this is important to see the difference. In terms of men, anorgasmia was related to complete inability to reach an orgasm, while in the case of women, it can be diagnosed when an orgasm is delayed or absent. And it is because those two symptoms, delay and absence of orgasm, are combined in one disorder. And I'm not entirely sure whether it should be like that or not, but it is according to DSM, which is Diagnostic and Statistical Manual of Mental Disorders. So I think those research followed all these clinical definitions, and because of that, those two things are used together. Just like in the case of men, female orgasmic disorder is related to many factors, including medical conditions or medications taken, alcohol overuse, a significant amount of stress, and of course other sexual dysfunctions. Because you can imagine that if you have other sexual dysfunction, by definition you would have a problem with achieve an orgasm. So it is, I believe, logical. Treatment includes a thorough interview with the patient, because this dysfunction is predominantly related to a psychological factor in women, and therefore an appropriate psychotherapy or counseling would be the most efficient. However, in some cases, medication should be included, so it is crucial to find out what can cause this problem. Another one is a female arousal disorder. This is what it's called. Or to put it in other words, a loss of sex drive. And it is defined as loss or significant reduction in sexual desire or physical arousal. It was introduced relatively recently in DSM-5, so it was, I believe it was less than 10 years ago. And according to research, about 41 of premenopausal women experience at least some type of sexual dysfunction, and of those women, of those 41% of women, roughly 28% experience low sexual desire. And unfortunately, there's no information on how many of lesbian and bisexual women have experienced low sexual desire and low sex drive, so I cannot really give you an exact number or exact percentage. However, according to DSM-5, female arousal disorder is characterized by reduced or no interest in sex, no thoughts about sex, decreased sexual arousal or decreased pleasure during sexual activity, infrequent or no initiation of sexual activity within a relationship, and reduced or no sensations in genitals during normal sexual activity. So those are things that should be present to diagnose arousal disorder. And of course, the most important thing is that one should feel significant distress about their symptoms. Because if you are okay with your sex life, if you are okay with your sex drive, and you don't feel you're lacking sexual activity, and your arousal and your sex life is absolutely okay and it's fine for you, there is really no reason to diagnose disorder. Because I gotta tell you, and I want you to remember it always and forever, there is no normal level of sexual arousal. And there is no normal level of sex drive in both men and women. If you don't feel distressed about your sexuality, don't do anything about it. It's okay. Since arousal disorder often stems from hormone imbalance, hormone treatment seems to be working best. And hormone treatment can elevate the level of estrogen or testosterone. It can also affect your vaginal dryness if that's the problem, and consequently, it reduces the pain during sex. And of course, when the problem is related to psychological issues, counseling or combination of medical therapy and counseling would be the most efficient. And the final problem that occurs in lesbian and bisexual women is pain-related disorder. And since women who have sex with women also participate in activities related to penetration, both vaginal and anal penetration, it is obvious that some of those women would experience pain. And the interesting part is that the most common context for experiencing pain was during a vaginal penetration. And in this case, there was no difference between women who have sex with women and straight women. And in addition, they both reported vaginal penetration as the one which was most likely to be related to pain. However, compared to heterosexual women, lesbian and bisexual women reported less pain or similar pain during vaginal penetration. And none of the studies that I found reported lesbians or bisexual women experiencing higher level of pain when it comes to penetration. That's quite interesting. But the good news about them is that pain-related treatment is relatively easy to apply and it is very efficient. When the pain-related symptoms are linked to dryness of your vagina, it means not sufficient lubrication. The direct form of alleviating them is just using lube. It's just as simply as that. And in the long run, hormone therapy might be necessary to regulate level of estrogen, for instance, and to maintain the proper lubrication. And another thing that might be related to pain is dysfunction in pelvic muscles. They might be, for instance, too tight, and the treatment in this case should include behavioral techniques like relaxing muscles, desensitizing body, and especially pelvic muscles, and so on. And finally, for some people, vaginal insert pills can be prescribed. Those are usually steroids applied daily at bedtime that could help reduce pain during sexual intercourse. And it is important, this is pro tip from me, the pills that are supposed to be applied to your vagina should be applied when you go to bed, not in the morning, not during the day, but when you go to bed. And I know that doctors rarely inform their patients about it, so that's why you got me. Intravaginal pills should be applied when you rest in the horizontal position. Otherwise, they're likely to fall out. Okay. That was a pretty lengthy episode, but I hope you found something interesting for you. I think it was useful for you. I believe so, at least. And if you like the show, you can, of course, support me by buying a coffee. The link's in the description. Thank you as always for messaging me and for inspiration for the next episodes. As usual, if you have any comments or complaints, let me know. I'll be happy to improve this podcast. And if you have any questions, don't hesitate. Just write me an email or DM on Twitter. And take care. Goodbye and until next time. Bye.